I would just start with the aspect of regular monitoring of PRAs. Professor Sundar sir, what is your experience on doing the PRA on a regular basis for your dialysis patients?
To be honest, we have never done PRA and I don't believe in it.
Yeah. Yeah.
So I don't think I can comment much, but it is not, because our number of cadaver transplant we are doing is not all that great. It is not even 5 to 10% of the total transplant program. Yeah. But by and large, I don't do PRA in my patients because it's still not easy to get it done. So that is the way. That's how we function in Bangalore.
Okay. What about Dr. Sribhushan? What has been your experience in doing PRAs on a regular basis for your dialysis patients who are on the cadaveric transplant wait list?
We have been doing once in 6 months in those patients who are affordable. And for the past 1 year, we started in our own institute actually. Okay. Because it's a free of cost and we can do that. As Dr. Sundar said, it's not really required in each and every patient. But we could find some of the patients who became very sensitive and we found them that they're suitable for desensitization protocols. And we have done few desensitization protocols and we went ahead with the transplantation successfully in them. So we need to select out. In fact, these patients are not second transplants and those who received multiple transfusions and where we suspected something wrong with them. It's not that. But not that not that everybody is affordable, and many good number we started doing it because our facility is available in our institute. Not that it's for a very great scientific reason, but second transplants even before that also we were doing it. We were getting it done from the other hospitals and we were doing it. Yeah. And it's an important thing only, but not that we should do it totally for each and every one. It's not really required.
I think we have to individualize and selectively do it.
Yes, sir. Yes.
Yeah. Dr. Srijit, your take on that? Srijit, you will unmute.
Unmute. Yeah. Unmute and...
yeah.
Where is he? Not seeing his...
Suddenly he has disappeared. Okay, now I think we'll wait for him to come back. The second aspect, which is very, very interesting, I found, was that about the pre-implantation. Srijit, what is your take on the PRAs? You will unmute?
Unmute.
Yeah, sorry, I got disconnected in between. I don't know what happened. So regarding the PRA, we don't do it uniformly for everyone. We primarily because not everyone can afford it. We assess immunological risk, so we do it for all people who are second transplant because a significant chunk of people who are waitlisted for cadaver are second transplant. So we do it on those people who are assessed to be at high risk, and then if they are found to be at high PRA, we do few sessions of plasma exchange and all, and give them IVIG, and we bring them to the top. So we have been following that. We don't do it for every single dialysis patient waitlisted. We triage them based on their immunological risk. So out of the around 80 aspects, we have done around 86 cadaver transplants in our this thing. Most of it are from our own center. The second transplants were at least I think, memory is correct, at least 20 were second transplants. So all of them, and some of them, when we find that when we call them, we do cross match, cross match is found positive, even though they are not a second transplant patient. So such people we do PRA and the usual high immunological risk assessment, and then we go ahead and do it. By default, we don't do it for everyone.
The other practical issues is that once you find somebody is highly sensitized, and you will never know when you are going to get a cadaveric kidney. So when do you desensitize? How do you wait for it? Because desensitization, you need to have a time frame. So it can be easily done in a live transplant rather than in a cadaveric transplant. Your take on that?
Yes, sir. What we have done, actually, this is an issue which we can't desensitize them and keep them. But what we have done is we had someone with the second transplant. We reintroduce CNI for them if they were off CNI, and we do one session of plasma exchange because we have around 12 hours time during render certification and all, because we do it all in-house. We call them, we do one session of plasma exchange around 1.5 volume and give them IVIG. And then we go ahead with the transplant. That's what we have done. I can't, but it has worked well. Nobody has developed hyperacute rejection. That's what we have done, and that is work for us.
What you have done is a very acute form of desensitization in a cadaveric transplant. Isn't it? So, very nice. So the next aspect is about the pre-implantation biopsies, which Professor Georgie has been doing. What is your take, Dr. Sundar?
I think it's, see, you must have the frozen section facility to get it in few hours, but we are not doing routinely. But if there is a doubt, I think we do, because the cadaver organ comes from different sources, it's not in-house. 90% is from different areas where the facility is not there. But in selected cases, I think we have done, and then we have taken action whether to use the kidney or not.
Yes.
But it's a good concept. If you can get it done, I think it's a good, as Georgie was saying, some of the kidneys which we should not use, we will be using. Some which we reject, we will take if you can do the biopsy. I think it's, if it can be done, I think that will be the ideal, it's the ideal situation.
Sri Bhushan, have you been doing implantation, pre-implantation biopsies? No, you are muted.
You're muted, Sri Bhushan. Unmute.
No? See, we have done a good number, because you know that our cadaver transplantation program origin is in our institute. So, and there is a lot of fight between the people also in taking the grafts, and sometimes they feel that this is not an appropriate graft. And you know that we don't have any transplant surgeon, we have a urology department. And they always try to evade, because they have their own big work compared to transplantation program, which is less than 1% of their work. So naturally, they
totally agree.
they try to push us into such a trouble of rejecting each and every graft, every kidney actually. So we try to get the frozen sections, and we try to show them that the graft is good. Despite that, they say no, if they are very busy or something like that. If they get into some 2020 match that time, or some cricket match or some film also, they try to cancel that for no reason, and we should not ask them also. We should not even question them. So such is the case. So we regularly do that. And we have done, in fact, Dr. Swanlata has presented some data related to these pre-transplant graft biopsies before they were taken. And in fact, it really helped us in good number of the cases. It really helped us. We were about to say no to them, but we got the kidney. And sometimes we could find that the patients had amyloidosis totally asymptomatic. And such kind of cases, patients who had non-diabetic patients had diabetic nephropathy changes. So in early diabetic changes also were seen, and some of the graft kidneys were very bad, and where we thought the creatinine was high, and some sepsis like AKI, and we got the biopsy done, and kidney was absolutely untouched inside, and we have taken the grafts, and they really did well. So these are the things, and we have done good number of the biopsies and frozen sections. Luckily, we have a very good pathology department with us, and they will just help us like anything actually. We do left and right so many biopsies. And when we go in the midnight also with the section, she'll come to the hospital, and she will see the biopsy, and then only she will go. And then we decide what to do with that. We have done a good number actually.
Yeah, great. So these are the needle biopsies or wedge biopsies?
Wedge biopsies done by the surgeon during the retrieval itself by them. We ask them specifically, because you know that many times many hospitals will be rejecting it. Not only the hospital rejecting it, the patient recipient, the so-called prospective recipients, they reject. Saying that no, this is good kidney, so why should I take? And these are the very common reasons actually. In fact, I was just telling the administrators also that if any patient says second or third time also reject, I don't want to take, just block him and just put him down. And you don't have to take him as one, and he becomes an obstacle, and he will waste at least 1 to 2 hours of the time in the big night. And this is very common. So that time actually this kind of a biopsies really helped us in choosing whether the graft is okay or not, and in convincing the attendants also that the kidney is good, and not to really worry about that. It really helped us actually.
The third aspect is about the single dose basiliximab. Again, a very interesting concept, because I don't think there are many studies on the single dose basiliximab. Whether the double dose basiliximab was what was the real scientific basis, whether single dose basiliximab itself is enough. So Sundar, your take on that?
Actually, see, basiliximab, in my opinion, I was one of the earliest used basiliximab in the country. It's not a very powerful induction agent. And I personally feel in a cadaver transplant is a high-risk transplant. There's delayed graft dysfunction. You can't use CNI. So I err on the side of using a few doses of thymoglobulin. So that way it gives me time. And especially if, as Sri Bhushan Raju was saying, we don't have a committed surgeon, the chance of ATN are high. In case the thymo gives us that much free time, few doses, and they've done well. So I personally, in a cadaver transplant or in a high-risk sensitized patient, I would not use basiliximab. I would use only thymoglobulin. And the single dose Similac, I was some of the days because of the cost factor. And if you remember our olden days of Zenapac, they used to give 5 doses, then came back to 2 doses. Still, I don't know the science behind using 2 doses of basiliximab. And my own impression after so many years of using both thymo and basiliximab is sort of a poor induction agent. But now people are saying that in the era of COVID era, because it is not so immunosuppressive, you should use basiliximab. That is one of the guidelines. If you look at the guidelines in the COVID era, they are saying use basiliximab instead of thymo. But I would still use low-dose thymo rather than basiliximab in my.
So what has been the experience of Professor Georgi in these COVID times? Have you used basiliximab or ATG in your patients in this COVID era? How many transplants have you done in the last 6 months?
We did 2 cases last month. It was blocked for some few months. And after that, we did 2 tests, both RT-PCR negative and donor negative. This was live related, not cadaver. One was cadaver. Of course, that donor also was tested, came from an elsewhere. The induction agent, I still use basiliximab. My policy is give basiliximab first dose. If they can afford, go for second dose. Meanwhile, if the graft function is good, if they cannot afford, restrict with 1 dose and observe them. If they have graft dysfunction, biopsy them. If it is ATN, leave it. If it is a rejection, treat them with ATG. That becomes more cost effective.
Yeah, I agree with you that almost many centers in Europe and Australia, they use basiliximab for cadaveric transplants, whereas in US, the situation is mainly ATG based. So now I think we'll go on to the second presentation by Professor Sundar. He will talk to us about his experience of doing the transplants during this COVID era, which will be very highly interesting and educative.
Can you see the slide? No. Can you see the slides? No.
Yeah, I'm able to. We are able to see. Yeah.
Okay. Now, at the outset, let me thank Emcure and Sampath for inviting me for this important session. I know we are living in a difficult time, and the last 6 months has been tough time. And if you look at our own experience, one is doing transplantation during COVID era, other is COVID in the renal transplant. So the 2 aspects. So talking of doing transplant in the COVID era, we have not done that many. The last 6 months, we have done a handful of transplantation. And as Georgie was saying, I think we have just had 1 or 2 cadaver transplant in this period. We definitely do the COVID test and then only go ahead with both the donor and recipient, then go ahead with the transplant protocol. And what I'm going to do now is just give you our own experience of managing COVID in transplants. I think that is very challenging. That is one of because the transplant patient is immunosuppressed. And this data is from my colleague, Dr. Vishwanath, our dynamic head of Department of Nephrology, and Purnima, a brilliant DNB students. We had 22 cases of transplant recipient having COVID. Initial part, the first 3 cases, we never used anything. We used only managed conservatively. Out of that, we lost 1 patient. Remaining of the 22, 19 had remdesivir, and they did well. That is our take-home message is using remdesivir early. Our dosage was 5 to 7 doses. They did well, and we invariably stopped the mycophenolate or azathioprine. In all the cases having COVID, that is what we did. All the transplant recipients who had COVID were admitted in the hospital. In-house, they were managed. Only 1 patient required ventilation in the ICU, and that is the patient we lost actually. So in addition to giving remdesivir, this is a summary of the 22 patients. 22 patients were admitted the last 4 months. 19 received remdesivir, 5 to 7 doses. 3 did not receive remdesivir because that is the time we started learning about COVID. Out of that, we lost 1 patient who was on ventilator. 1 received remdesivir and also tocilizumab because despite remdesivir, the inflammatory markers were very high. Our team thought tocilizumab would be ideal, and the patient recovered well with this. And then the problem in 1 case was fungal infection, and 1 had antibody-mediated rejection in the remdesivir group. There is some information that those who use tocilizumab in fungal infection should be more, but we have used only 1 case, so we can't comment on that. But our protocol is all patients having COVID, the mycophenolate and azathioprine was stopped. The CNA dose was not changed. They were in the pre-COVID time. And all of them were on prednisolone. We shifted to dexamethasone, 6 milligram BD, or OD, or methylprednisolone. That is during the hospital stay. In addition, they received azithromycin 500 mg, zinc and vitamin C, whatever was worth. And all of them had one other IV antibiotic, either Magnex or ceftriaxone. And all during the hospital stay received fragment. And we didn't use colchicine or hydrochloroquine as a routine. And that has been our experience. Recently, my colleague, Dr. Vishnath, told me that 1 patient is managed as outpatient, transplant patient, that is the 23rd is bad. A patient couldn't afford hospitalization. No remdesivir, managed conservatively, stopping mycophenolate, doing well. So this is the problem we are going to have in the COVID era. The question now comes is, all transplant recipients should we do, even if they don't have COVID? That is a common question which is being asked. They don't have COVID, should we do with immunosuppression? So I think that's what we should discuss. But in summary, I can tell you, it has been very encouraging. We have learned over so many months what to do, what not to do. And I think the consensus has been definitely stopping mycophenolate or azathioprine, using only tacrolimus or cyclosporin with steroids. That is the protocol. And our dialysis unit, actually, many of them are on colchicine now. They are getting as prophylaxis colchicine. So we should see now what happens with that. That is the protocol we are following.
Yeah.
Thank you.
Thank you, sir. That was a great show of recovery in your transplant patients. If you go by the literature, the mortality is close to 30%. International mortality is 30%, and you have had only 1 mortality in your 22 patients.
1 death.
It's a great news.
Correct.
And so I think this is very important news for the whole community. Dr. Sribhushan, have you been using remdesivir in your patients? And what about Dr. Srijit? You are all in the front line of departments where these drugs are flowing like water.
Yes. In fact, we have admitted a good number of transplant patients, and we have a total of around 16 patients so far admitted with us, and I have another few patients and good number of other cases by phone call and by, it's not truly like a telemedicine, but they just take my opinion because no problem, I'm easily available to everyone, not an issue. Yeah. And I've been giving advices, and not only advices actually, but I was trying to simultaneously learn out of them, because every doctor is something different in their own way of dealing with the patients and thinking. And then I was just listening to, in fact, I was accepting every phone call from unknown people also, especially the transplantation CKD people and all, when they were telling me about, see, today is my 10th day and I was given this particular drug, and then I was just asking them, what was your other reports like LDH and IL-6 and other thing? Were you given any other new drug, remdesivir? And now, thanks to the media and all in newspapers, that every newspaper has become a medical journal.
Yes.
Rather than reading our own journal is of no value now. You can read a newspaper and you will know everything about remdesivir and its complications, adverse effects, indications, contraindications, and experiences of all. So like that, every patient is very familiar. In fact, I could not really pronounce properly the particular new drug, flavipiravir or something like that. But my patients were able to do easily and diligently. So, and they themselves were telling about all the drugs, the doses, and how they were treated. So I was just trying to learn out of their own, so that I can use it, the experience, for my own patients. And we had both the units of our department, 16 patients were admitted, of which there were 4 mortalities. And 4 mortalities were basically they came very late. In fact, I've been telling them 2 patients, 3 patients in 2 patients, 3 patients in other unit and 1 patient in our unit. And all the patients, actually 4 patients, I realized that they came very, very late. This particular patient is a young fellow, 10-year-old transplant. And he just wasted time, and he was laughing at me when I told him that you have to come down immediately. And he was laughing at me, no, sir, I'm okay in the Singareni College Hospital and I'm happy, comfortable. I said, no, please, you're a transplant patient, you're precious, and some of the reports are not good, please come. He didn't come. I realized that those people who came to us very late, they died. And now there are 3 patients who are admitted. Now all of them are doing well. One old man is just recently transplanted in the month of March, first week. It's a cadaver transplantation program. We didn't give any remdesivir, and we just give a methylprednisolone and hike the dose of it. I don't think that why should I really kill the kidney, and I didn't really stop the immunosuppression. He improved automatically. He's a bit old, a 64-year-old and a bit obese man, and is a diabetic also. And despite that, he's doing very well. Graft is still good. And we have given cytozab. In fact, I should really tell you that we did cytozab, and rather than in fact, we had simultaneously cytomegalovirus infection also, though he has been taking ganciclovir. So we have given some IVIG also to control probably it's a 3-6 months now nearly, and still he has got the CMV positivity. So we gave some IVIG and cytozab we gave, and he responded very well. And the cytokine levels were interleukin 6 were very high, and not high, it's around 20 or 30. So we did cytozab, and he improved actually. And then afterwards, I think now it's everybody's experience, and I should not hide my own ignorance or probably this thing also. I did plasmapheresis also to him. I told the attendants that whatever he knew, I don't want to do to my transplant patients, because I don't know how the remdesivir reacts, how the atocilizumab reacts, but rather I know how my patient on plasmapheresis reacts, because that I've been giving for the past 20 years now comfortably. So he responded very well to simple plasmapheresis, and of course it can be a routine recovery also, and he responded very well. Now he is totally comfortable in the ICU. He was an NIV, and his oxygen requirement has come down. He was taking some CPAP and before because of obesity and all. He is doing well now, even now. We were able to shift him yesterday itself to the private room. He has been waiting for that. So this is my experience. And other patients, I never gave remdesivir to anyone, tocilizumab to any of our transplant patients. We gave to other people. And remdesivir has been given very good number of our patients, including CKD patients, by our Institute General Medicine Department. And I've been listening to them in the everyday 3 to 4 because their own meetings which they organize. And I was just trying to understand them, how they were treating. And some of the patients were having a kidney disease, and they were treating them, and not much of worsening of the kidney function. And not many really required dialysis also. No other problem happened to any of our patients. And only one staff father, and he had a worsening renal failure which was there before also, and he required dialysis. And otherwise remdesivir was given to anyone, and other than this, 4 patients died out of 16 patients who were admitted with us.
Sri Bhushan, you said you used cytosol for all your patients.
Only one.
Oh, only one.
Only one. And this patient also, because he's in ICU, then I thought I should try, and I was very much against plasma therapy as a rule. I don't know, I have been talking very much against plasma therapy in the media everywhere, and I didn't want to. It's a funny concept. I thought probably it's one which comes just like that without any effort. I don't think it will work. Either the knowledge or probably the money or fame or popularity, including the antibodies. So I never believed in that. That will come just like that, and it will protect somebody else's body. I don't know. It's my thinking.
Recent ICMR study was against it.
So I've been telling that right from the beginning. In fact, I wrote one article also to one editorial to one of the leading newspapers here in Telugu. But I stopped it. I told them that when film personalities are talking about it, when IPS people are talking about plasma therapy, come and donate. And film people like Chiranjeevi and you must be knowing Vijay Devarkonda and big film heroes are actually talking about plasma therapy and come and ask. Then why should I write an editorial on that, saying that it may not be some good value? Who will listen to a scientist or a doctor, and who will listen to that? So we are not celebrities to talk about it. That's why I stopped it, and I sent another editorial to them, a different editorial to the particular paper rather than this plasma therapy. So in fact, I was worried about the plasma therapy in our transplant patients. Though our ICU critical care people were insisting that we'll give plasma therapy, I said, please don't give that. Our transplant patient will be, is recently transplanted. There may be some antibodies which can act against that, and I'm against that. Please don't give it. So luckily they could understand my sentiment with the transplant, and we went ahead with the cytosorb, and he responded very well. 2 sessions of cytosorb we have done.
Okay.
And first one for 22 hours, second one for just 11 hours, it got clotted. So because it is 80,000, 83,000, each cytosorb cartridge is 83,000. So I didn't want to trouble them. So two sessions we have done, and we stopped it. And then afterwards, I simply said, did a plasmapheresis, and he improved further actually. He improved further with that. His condition and other parameters also have improved.
Yeah, Sri Bhushan, after the cytosorb therapy, did you do pre and post IL-6 levels?
Yes, that I need to really check that. I told them to send it.
Yeah.
I told them to send all the parameters. My students have definitely sent it. I need to collect them actually. It is just 1 week old. I'll collect them, and I'll next time, whenever the day discussion, I'll try to present that.
Dr. Srijit, what has been your experience with remdesivir in both CKD patients, dialysis patients, and renal transplants?
Yeah, so we have had kidney disease patients, excluding transplant, around 46 patients admitted till now. And transplant, we have transplant recipients, 8 of them admitted with COVID with us. Out of the 8, only 1 was severe, in the sense he had hypoxia, he was requiring high flow oxygen. He was a disease donor recipient. He was relatively young, but then he was obese, and he was always having uncontrolled diabetes. He was requiring hypo. He actually required NRM, non-breathing mask and all. But then he has improved. Actually, he has also come out, and we have not used remdesivir in any of these patients, because most of them were mild, except this one. All of them were mild, and in fact, we didn't stop MMF in any of them except this particular patient. What we did is we reduced the MMF by 50%. We didn't change the TAC, neither we changed the prednisolone. For this moderate severe fellow who was having hypoxia, we changed it to dexamethasone. We stopped MMF, and we continued. We rechecked the TAC level so that just to be sure that it's not too high. It was around 3.8 or so we didn't change the dose. Our experience so far with transplant has been pretty good, in the sense we had 8 of them, only 8 of them, that's not a great number, but only 1 had features of pneumonia requiring oxygen and all. The rest 7 were all mild. They had coryza, they had myalgia, they had fever, but within a couple of days of admission, they became febrile, and none of them had hypoxia, so they all did well. Some of them did have some rise in creatinine, which I presume is not rejection, because most of them settled on follow-up. Right now, there is a patient who is admitted. The lung is not bad, but she has significant pre-existing significant anemia. In that way, she has some hypoxia. So the transplant experience has been pretty, comfortable and not too bad, but not great numbers. 8 is not a great number. The other people, dialysis, actually, we just presented our data in our own internal scientific forum. We had out of the 46 patients, around 20 were ESRD people. Right now,
this definitely was an improvement, and the authors concluded, this was again from ASCO 2020 this time, that anti-tumor activity of pembro was shown in non-clear cell RCC, including all the IMTC subgroups, all the PD-L1 status and sarcopenia differentiation. 19 of the 44 patients who responded had ongoing response, again what Dr. Raja showed very easily. And again, very importantly, patients who had a more than 80% tumor reduction and survival rate is similar to people who had achieved a CR. So you don't need to achieve a CR. You probably will. If you have 80% reduction, you're going to do as very well. Now, my last slide, there was a question asked about the sarcomatoid carcinoma in the chat box over there. And sarcomatoid carcinoma, I will just show this. This is not current origin. The Central has the popularized IU combination by saying IU combination. I am going to say Nivo AP as current Johar probably. And this data was published in the 8th September 1st, 2020. And if you see, Nivo AP was compared against sunitinib in first-line treatment of patients with advanced sarcomatoid RCC. And look at the PFS that we have achieved with the Nivo AP combination. That was 26.5 months versus 5.1 months in Sutent arm. And that definitely was very impressive. And if you look at the
renal transplants and the challenges which face, and each patient presents with us with a different challenge, and as you agree, the experts who have gathered here had their own way of meeting the challenges head on and succeeding. So if you go by their experience, I'm sure all of you must have got great great education. I think as a parting shot, we'll have some crystal ball gazing. We'll start with Georgie Nayanan sir. What do you feel is the future for renal transplants in the next 6 months down the line for India?
Yes, COVID is becoming a part and parcel of our life. We have to take the standard precautions which we are all taking. And COVID will be there for some more time till the vaccine comes, good quality, immunogenic, antibody response and prevention. So that is one side. So we are going ahead with transplantation. And I should tell you that transplant patients and dialysis patients are very, very careful. It is the bystanders who create a problem. They are the people who go out, come and import this corona to the family. So my feeling is that corona will continue. We have to be, as a physician, we have to be careful in our dealing. Any fellow sitting in front of you is a potential asymptomatic corona patient. Treat him like that. And then I am encouraging more telemedicine. Fortunately, nephrology is something where you can do telemedicine. We had so many peripheral units where dialysis. If you have got all the data, you can help to conclude to a great extent. Transplant patients, monthly checkup, they call, you can follow it up. New transplants, do it selectively.
Yeah.
But if you get infection, mortality rate is high. That is the message we have got from the other experts from Hyderabad and especially Hyderabad group. The mortality rate is very high.
Sampath, I think Georgie was saying we have to live with corona. It's not going to go away. But what is worrying is the fear of the disease is causing more problem. Because of the fear of COVID, our own transplant patients and other people are not coming for treatment, which is more dangerous. And doing transplant in the corona era is challenging. But as Georgie rightly said, the transplant patients are careful because they know they are immunosuppressed, they wear masks, they take care of, they already got the social distancing. All these things are being followed. So there is no issue on that. One other thing is what we have to discuss is also what we are doing now. People going for transplant at this juncture, we are taking a special consent form because we can never predict what will happen. Transplant even without COVID is dangerous in my opinion. So it's not easy and nobody can predict that. As Sri Bhushan Raju was saying, nobody knows the science of transplant. Transplant is such a thing, it is very difficult to predict. I mean, there is science, but still we are not able to say which patient will do well, who will not do well, who will get infection. There's no scientific algorithm to tell us. So by and large, they come with trust. Patients come with trust. We have to deal with that, but we have to protect ourselves. And as Georgie rightly said, we have to consider every patient not only as a potential COVID patient, every patient as a potential litigant also. That is very important. So medical legally also, it's better that we tell them, take them into your confidence and discuss and go ahead. That is one. But somehow cadaver transplant still not picked up during this era. That's what is my feeling. It's still going to take time. For some reason, it's still not picked up the way the other things are picking up. So that is my message.
Possibly because of the reduction in the road traffic accidents, the cadavers are not coming up. So that's a good sign, I think. Sri Bhushan, your take on that? Yes.
Yeah, cadaver, in fact, interesting thing is that in Hyderabad, one corporate hospital has done 4 lung transplants during this particular time, 4 lung transplants. And one has been flown from Kolkata. And
I saw the news.
3 from, I think, within Hyderabad. And Dr. Swanlata was also telling me, and we tried to get the kidneys also for the particular patient. But none of the hospitals and none of the surgeons were keen, including our own surgeons. And I don't comment much about our surgeons because they do around 120 transplants for us every year. So this year they have done exactly just 15 transplants, only 15. And not more than that. And they're very happy. In fact, they must be very happy that they got rid of the very troubling nephrology. And they're enjoying the day also. So cadaver transplantation definitely will pick up. The way I could see that, in fact, cadaver, the lung transplant they have done, and next step I will push them even for cadaver kidney transplantations and others also. And our department of surgical gastro, I'm about to start next 2 weeks the liver transplantation, which is live. So one problem with that, probably our urologist might take some clue from them and get boosted in Renal, and they might start also, and we'll be definitely doing that. The other one about the transplantation program per se, that we have not yet come out of the era of tuberculosis, cytomegalovirus, and sepsis, mucormycosis, and nothing, urinary tract infections, nothing. We did not come out of any of these infective eras. I think the Rubin's table, the timetable will have another infection among the 2030 label. We have another COVID also. When the COVID will come and the COVID will end, probably first 3 months or first 2 months or first 1 week or something like that. So Rubin table, if it is modified again in this era, probably COVID also will be included into that one particular. But I don't think we should really go out of transplantation program just because the COVID. Probably from November or December in full-fledged way across the country, I predict that we are going to start, because we have come to know how to treat and how to manage, how to predict. Not only that, we know how to diagnose very easily. In fact, we have been doing just like that in the ward only. In fact, our ward has got 50 to 75 kits of rapid antigen kits, and our laboratory also can do 2,500 to 3,000 PCRs every day. And we are going to get the report within less than 12 to 13 hours. If you send it and maximum by less than 24 hours, we are going to get the report. So PCR is also okay. Rapid antigens, we are just like that doing left and right. Even in the OPDs, whenever, before admitting every patient and their attendant, 2 of their attendants, we are doing it. So in that way, so what's the problem in that? So we should have our own protocol and see that they are actually well prepared properly, and then we can go ahead with the transplantation. And once, at least twice, you can see them, the rapid antigen and PCR both are negative, and keep them under isolation 2 days before transplant. And every time you do it again, RAT, and then you go ahead with the transplant. And anyhow, post-transplant, the isolation and the management of sepsis is going to be the same for each and every patient, irrespective of whether they have COVID or not. So it is the same kind of a thing, and we should tell them to abstain from meeting anybody else and taking care of all the precautions that are applicable. So I predict that the transplantation program is going to really take a boost from probably October, November onwards. November, December, you can see full-fledged, and that should not be a problem at all in our transplant. That's my personal opinion. Yeah. But in individual hospitals and individual scenarios, setups will really make a difference, because not every setup we can do just like that PCR, just like that RAT, because the government is providing us free of cost that rapid antigen kits, just like that. And the moment 75 is over, immediately another 75 will be released to us. Once you provide the data to them, who are the people who underwent RAT. Otherwise, we'll just like that get. But not that every hospital will have the same facility, and every state also the same facility. So it is something different in every, but we should go ahead with the transplantation according to the seniors who spoke. I feel that we should go ahead with the transplantation, taking all the precautions.
Yeah. Srijit, what is your institutional policy going to be? How is it going to be changed?
Yeah, so actually, our institute policy, as well as personally, I think that there is no reason not to do transplant, except right now we are swamped with COVID, and including myself, we are doing ICU duties in the COVID ICUs by turns. There are 3 faculty, and we are deployed in the COVID block. So that is the logistics is what is stopping us, not really the science. We are of the very clear view that we can do and we should do transplants, but unfortunately we have to wait till this we are a bit free from the COVID responsibilities. The COVID block, we are having more than 400 patients, and there are a lot of dialysis patients, so we are entirely into COVID management. Even though we are a COVID as well as a non-COVID hospital, the non-COVID part is very minimal now, around 20%. Our entire workflow, manpower and equipment, ventilators, all are focused on the COVID block. So my view is that as soon as the COVID burden comes down and we are free to take care of our routine work, actually we are managing nephrology purely by teleconsultation now. We have a HIS, and we have been doing it right from May. There is no in-person OPD consultation, otherwise they have to come to emergency and get admitted. Inpatients are only through emergency. If they get admitted, they come to us. The MSD unit, of course, is maintenance dialysis unit is functioning like normal. So my personal view is that, and the department policy is that as soon as we are able to spare ourselves from the COVID burden, and we are able to restart our routine nephrology, OPD admissions, we should, and we will be restarting transplant, of course, with all the precautions. There is no restrictions on the testing, be it RT-PCR or including the serology as well as rapid antigens are freely available now. there is no reason to withhold, because even though we have dialysis, I think we are all aware that keeping a patient, when there is a donor available, especially living donor, it is not ethically right to keep them on dialysis indefinitely. And this COVID thing is definitely not going to end anytime soon. This threat is going to remain, and we should restart those centers where nephrologists and nephrology facilities not stretched to take care of COVID. They should be doing already. For a place like ours, as soon as we are less of COVID burden, we should be restarting transplant. That is my view on it, sir.
I think thanks for all your inputs. So I'll just summarize by saying that, as Professor Sundar was mentioning, we are in an era of uncertainty, and there seems to be some light at the end of the tunnel. We'll only know by November whether that light is really a bulb or an speeding train for the second wave of corona. So we'll have to wait and see.